Good morning and welcome to my presentation of a focused wound assessment. So beginning by introducing my patient. He was an 11-year-old boy weighing 45.6 kilos, 155 centimeters of Caucasian background. He came in for a posterior spinal fusion 5 days ago, was discharged 1 day ago and re-presented with pain and large amount of ooze from his wound. He then returned to theatre for a washout and closure of that wound. Background of idiopathic scoliosis with immunisations up to date, and some social factors were his parents were married, he had one other sibling, and nil legal issues. So current assessments of the patient, he was age appropriate and orientated. Diet, he was on a full diet, having small frequent intakes. Vital signs were within limits for his age, with a constant temperature, however, of 37. Bloods were found to be within limits with a slight drop in HB and an increase in CRP of 62. The X-ray was found that all of his screws and metalwares were in place. The patient reported a constant 5 out of 10 pain score, regardless of having constant analgesia in place. He was neurovascularly intact with full sensation movement in all 4 limbs. Mobility-wise, he was supervised walking 100 metres, otherwise would use a wheelchair to transport. The dressing to his back was a Pico dressing and it was intact with moderate amount of ooze, and that was changed 20 minutes prior. So by beginning a wound assessment, it is important to understand the physiology of wound healing combined with the knowledge and actions of dressings and products needing to be applied, and continuing those assessments and dressing changes and documentation to facilitate in the wound healing. And beginning with a wound classification, the wound was identified as an acute wound, as it's expected to advance through phases of normal healing and result in complete healing. The type of wound was delayed primary intention, as the patient went back for a washout and debridement and reclosure of the wound a few days post the initial procedure, which at this point we can then sort of look at the factors of wound healing, which are the physiology of wound healing, which is divided into 2 stages. The first stage being hemostasis, which involves vasoconstriction, platelet response and a biochemical response, and then the second stage being tissue repair and regeneration, which on assessment the wound was found to be in the inflammation phase, which is anything from 0 to 4 days and is the body's normal response to injury, which activates vasodilation, increases blood flow, causing heat, redness, pain, swelling, and loss of function. And wound exudate may also be found at this point, which is the normal response. So the type of wound we have is a surgical wound, as it was a surgical incision site. The wound bed on appearance was granulating, which is when healthy red tissue is observed and is during the repair process. And the wound measurement was 45 centimetres, which was just performed with a measuring tape. On inspection, the wound edges, we found erythema and regular normal pink tissue in colour, which pink tissue identifies new tissue growth. However, erythema can indicate physiological inflammatory response or cellulitis. There was no evidence of contraction. There were no raised or rolled edges, which can indicate hypergranulation and can hinder healing. And there was slight increase in changes in sensation due to increased pain at the site. But apart from that, as we stated before, he was all neurovascularly intact, so neurovascularly there was no concern. The exudate, however, due to the dressing being changed 20 minutes prior, and there was moderate sanguineous exudate present, which exudate is a natural part of the wound healing process, and it can assist by containing nutrients, energy, growth factors for metabolizing cells, contain high quantities of white blood cells, and cleanse the wound maintain a moist environment, and promote epithelialization. However, excess exudate can lead to maceration and degradation of the skin. The surrounding skin was intact and soft. So we then moved on to interpreting the findings of the wound assessment. So we found erythema present, moderate exudate, nil odour, moderate localised pain with constant analgesia, warm localised and systemic temperature, and nil edema with a pain score of 5 out of 10. So here, beginning to interpret the findings, we start to look at the presence of infection due to the erythema and the increase in exudate, the localised pain and the localised heat, which, as said, the patient was having systemic temperatures of 37. So infection can disrupt healing and damage tissues of local infection or produce a spread of infection or wound dehiscence. So we then need to look at the management of a wound in this case. So our goals for wound management are to promote a multidisciplinary approach to care, perform an initial wound assessment, and then continue to assess the wound, especially when there is a change in condition. Consider psychological implications of a wound, especially in a paediatric setting, as developmental understanding is very important and pain associated with the wound and dressing changes. Have a goal of care and expected outcomes. Respect the fragility of a wound environment. Aim to maintain bacterial balance using aseptic technique and maintain a moist wound environment. Maintain a stable wound temperature, so avoid certain solutions or wound exposure. Maintain acidic or neutral pH. Allow heavily draining wounds to drain freely. Eliminate dead space. Select the appropriate dressings and use appropriate techniques based on the assessment and the findings. Instigate appropriate wound therapies and follow principles for managing acute wounds. So for this wound, we look at what dressings we would use for a wound of delayed primary intention. Things such as normal saline compress, amphigerous hydrogels and hydrogel impregnated gauzes to assist with further debridement, calcium alginate ropes or ribbons, hydrofiber ropes or ribbons, drainable wound osteotomy appliances when there's larger amounts of exudates present, and things like foam. So absorbent or protective secondary dressings will also be required for most wounds, as we need to protect that surrounding skin from becoming macerated and having further deterioration of the wound. So management for this patient, as he needed to be discharged, we then organised for a specialist clinic appointment where he would follow up for wound care a week after his discharge. And whilst he was back in the community, we had a wound plan for the patient that we discharged him with, and informed them that they would need to see their GP regularly, either every day or every second day, depending on the drainage of the wound for those dressing changes, and recommended that the family take photos so that we could see how the wound was being managed in the community when the patient was to return to clinic in the hospital. The patient was also to have antibiotics as prescribed by the doctor to help to heal that infection that we have identified, and to continue to take analgesia to improve his mobility and comfort and reduce the inflammatory response. Then, due to him being a younger male, just general things like hygiene and pressure area care whilst he was at home. Also, because the pain was a hindrance to his healing and the healing process, we had pain management team see him. He was prescribed with a quick release and a slow release analgesia. We talked to and educated the family about other things that could be used, such as diversion therapy, controlled breathing, hot and cold compresses, and awaited for the patient to then be returned to the hospital so we could continue his wound management. And that concludes my presentation for today. Thank you.